Thank you, everybody. So I'm here to talk to you about some of our experiences that we've had in Canada. So, thanks Dan, and thanks everybody from Turning Point for allowing me the opportunity to speak to everybody here today. So maybe first I'll begin by just talking to you a little bit about the organization that I'm from. So we're from the Canadian Centre on Substance Use and Addiction. You might notice from our acronym, the CCSA, our name used to be the Canadian Centre on Substance Abuse, but over the last year, or about last year, we actually decided to change our name to the Canadian Centre on Substance Use and Addiction, as we were receiving a lot of comments from partners that abuse was kind of a stigmatizing term, and it was really kind of important that we don't stigmatize people who have substance use dependencies, and So we changed it, and I think it shows a bit of the direction that Canadians and a large part of the world are moving when it comes to issues of substance use and dependency. So our organization was created by an Act of Parliament about approximately 30 years ago. We're expected to be an arm's length organization that provides unbiased evidence to the Parliament of Canada. Most everything that we do is in collaboration with partners from across Canada. These include those people who are in service delivery, working in harm reduction, working in prevention, drug prevention, treatment, as well as in enforcement. And our mission really is to address issues of substance use in Canada. I'd like to acknowledge that the information I'm presenting here today is made possible from a contribution from Health Canada. However, the views expressed do not necessarily reflect the views of Health Canada. So I think today what I'm going to do is really I'm going to kind of talk a little bit about, just give you a bit of an idea about Canada, and then I'm going to give you some information about a study that we had done on the cost of substance use in Canada. And then I'll do a little bit of a deeper dive into talking about the opioid crisis in Canada and some of the factors that some of the responses and some of the factors that kind of drove that crisis. So Canada, we're a very large country. We have one of the, we're not large in terms of population, but we are one of the largest countries in the world. We're the second largest country in the world, 6 different time zones. And we have one of the largest per capita immigration rates in the world. About 60% of our population is English, and about 23% of our population native tongue is French. Healthcare is delivered by the province. Most of the police forces are provincial. It's very different and very hard to aggregate and compile and pool into one single into a single database. And so it makes it extremely challenging. And healthcare is administered by the province. Just an overview of kind of drug use. So, alcohol, tobacco, and cannabis are our drugs of choice. I think that's probably similar to Australia, yeah. Cannabis is quite popular. I was struck by walking along the streets of Melbourne and not smelling weed wafting everywhere. It's actually like right now Canada's going to legalize marijuana on October 17th, like recreational use of marijuana across the whole country. And we're in a bit of a legal netherworld right now, where it's neither legal yet nor illegal. And so they haven't set up the government shops to distribute it. And so literally, like within about 2 or 3 blocks from my house, there are I've counted 5 dispensaries. They call them dispensaries because previously it was for medical purposes. And you can know, and the restrictions on getting the cannabis for medical purposes is probably not high standards for getting those. Like you kind of walk in and say, "Are you sick?" And yep, and then what do you want? So it's really right now, and the police aren't doing anything about it because what do? We're going to be legalizing this in a few months, right? So right now it's a bit of a strange. I suspect that on October 17th they're going to clamp down on a lot of the legal distribution, and things will change quite significantly at that point. But opioid pain relievers. So 13% report past year use of opioid pain relievers. that's fairly high, I think. And that's even after there's been a lot of physician education about the abuse potential or dependency potential of opioid pain relievers. Among these, about 2% report past year non-medical use. And the other thing that's interesting too, and this is from having conversations with our American partners, is we see in terms of the actual, we see a lot more similarities in trends that go north-south here rather than across the country. For example, in British Columbia, Vancouver, there's a lot of heroin there. We know that. There's also in Seattle and Washington State, which is right down here. Nova Scotia, partners at the RCMP have indicated that I don't think they've ever seized heroin in Nova Scotia before. But they have an opioid problem. It's just mainly prescription opioids. So there's a great variety differences across the country, and we're trying to work a little bit closer with our American partners to kind of just talk about how can we compare those cross-border trends. This is a study we released in June, just of this year. This was a study that we spent about a year and a half working on. It's looking at the costs and harms of substance use in Canada. And it'll give you a bit of an idea of what the trends have been, because this is an aggregation of a lot of different data sources. This is our project team. So I know my co-principal investigator on the project was Dr. Tim Stockwell, who I know used to work here in Australia. So I think he's maybe known to some of you, but it's been quite some time, so maybe not. So for this project, what we did is we looked at estimates between the years 2007 to 2014. And these are the categories of substances that we looked at. So we looked at alcohol, tobacco, cannabis, cocaine, opioids, other CNS depressants, other CNS stimulants, and all other psychoactive substances. And then we assessed costs against 4 categories. It was a fairly standard substance use cost study. So I know there's been several done in Australia over the last decade or so, right? So it was a very similar methodology was used. We employed the attributable fraction methodology. So I'll give a brief description of it. So one of the things we know is that at least in both the healthcare domain as well as crime, we know that there are some conditions or events that are 100% attributable to substance use. So these would be, for example, we know the World Health Organization has indicated that a certain proportion of stomach cancers are caused by alcohol consumption over and above a certain level. So we know a certain proportion of them. So, but not all stomach cancers are caused by alcohol consumption. So this would be considered a partially attributable condition. We also know that any opioid poisoning, like a T40 code in the ICD-10 coding system, would be a condition that would be considered 100% caused by opioids. So between the two things, so what we can do is if we can look at all of the conditions that would be considered 100% attributable to a drug category, and then we can also look at a proportion of the conditions that would be considered partially attributable to alcohol or other drug use. And so what we do in the attributable fraction approach is we look at the condition, and then we look at what is the relative risk of that condition given a certain level of consumption or a certain level of exposure in the population. And anyway, I won't get into a lot more of the detail there unless you're interested. But what we can do then is we can combine the 100% attributable conditions with the partially attributable conditions and really have a full assessment of the impact of substance use or specific substance use in a population. I'll maybe jump by this. This is some of the strengths of our approach. We developed. Maybe I'll make one note though. One of the things we did do is we worked with the Correctional Service of Canada and developed updated attributable fractions for substance use crimes. And so this was a big project, and it's quite exciting. I get quite excited about it. When offenders entered penitentiaries in Canada, they were given a survey called the CASA, the Computerized Assessment of Substance Abuse. And on that survey, they were asked, would you have committed the crime for which you are incarcerated had you not been under the influence of alcohol and then had a whole list of drugs? And then another question they asked was, did you commit the crime for which you were incarcerated for to either acquire this alcohol or other drugs, or acquire funds to acquire alcohol or other drugs? And through this survey, we were able to kind of come up with an idea of a kind of a causal attribution between substance use and crimes. And we had a population of 29,000 over a period of there's about a 12-year period of incarcerated federal offenders. So through that, we were able to come up with attributable fractions for crime, which is a nice addition to the literature, and we're going to be writing that up to publish. So we incorporated that. If you're interested more in that, I can tell you a bit more about that. So our healthcare categories, I'll breeze by this because a lot of these categories are really from in your alcohol and other drug tool. They mimic that. I had an opportunity to look through that tool. It's an amazing tool you guys have. So our health categories kind of are a bit similar to your alcohol and other drug tool. This is just a table that's meant to impress people with how much data we looked at, and this one as well. We also included lost productivity estimates. So these were included for both what would be the estimates associated. So lost productivity would be, these are called indirect cost estimates. And so these are what would the individual have contributed to the economy had they not either died prematurely or gone on long-term disability due to a substance use related condition. So we also look, and we also calculate short-term disability. And these are our data sources. Then criminal justice. So we took the attributable fractions that I told you about how we came up with them, and we applied them to the costs associated with policing, corrections, and courts. It's interesting, the criminal justice cost categories, there's a couple of different elements here. There are partially attributable crimes, so when we look at the attributable fractions that I was talking to you about. But then there's also the calculations where we have what's called drug-defined crimes. And drug-defined crimes are crimes that would not have occurred were it not for the prohibition of drugs. So it's kind of a tautology, right? So it's like we're defining this as a crime, and now you're getting charged with it. But had we not, and this is kind of important when we get into the legalization of cannabis, right? Because I'll show you some of the data that shows, the proportion of crimes that were drug-defined among cannabis crimes. This is just another direct cost categories, which is another group of costs that we looked at. They make up a fairly small proportion, so I won't use our time kind of talking about them. So what are the results? So surprise, surprise, we have the most cost from alcohol and tobacco. The costs of substance use in Canada in 2014, which was the most recent data we had for our death data, because lost productivity makes up a large proportion of our costs, we have data for healthcare, criminal justice, and other direct costs, more recent data than that, but the death data we only have data from 2014, and we didn't want to simply extrapolate or impute the data and then have it make a large chunk of the cost category, because a lot of policymakers were interested in using this, and the alcohol industry just lost their so they were ready to, the alcohol industry was just ready to jump all over this study. They were asking for updates all the time. We had to really manage the rollout of this very carefully. They especially didn't like the fact that alcohol is higher than tobacco. That was not good. So we have, about $1,100 for every man, woman, and child in Canada. And the legally available and most widely used substances accounted for almost 70% of the costs. This is the breakdown of the kind of categories. So as you can see, lost productivity accounted for the most. Healthcare was second at about 29% of the costs. And then criminal justice expenditure came in third. This is a breakdown by province and territory. And this won't be as interesting to you, but I do want to point out one thing is that if you look down here, you see the territories are very high. The per capita costs in the territories are very high. This is due to a couple of different things. I mean, we do see higher rates of smoking and alcohol use in the territories, and this is in some respects a function of the fact that there's a greater percentage of our Indigenous population lives in the territories, and our Indigenous population experience much greater harms from substance use than other elements of the population, other subgroups in the population. But it's also very linked to the healthcare service delivery, and treatment is much more expensive in the territories. So it's a combination of the two things, but it certainly it's very costly in the territories to treat, well, not to treat, but just substance use costs a lot in the territories. Tobacco is still the deadliest substance, so we found that there was over 255,000 hospitalizations. Now, I'm going to tell you a little story about our rollout here. So these are modeled estimates, right? Even the deaths here are modeled, right? So these aren't one-to-one. Each individual here doesn't represent a single person, and that's because of what we were talking about before, because we took a percentage of stomach cancers attributed to alcohol, right? So these are modeled estimates. The cannabis ones are all related to either impaired driving accidents or lung cancer. So, you know, there's a lot of debate about the connection between lung cancer and cannabis use. We consulted quite closely with one of our advisors on here, Dr. Jürgen Rehm, who is really kind of, in a way, the godfather of cost studies in a way. And he advised us that, you know, well, you probably do want to include lung cancer because we do think the WHO is probably going to proclaim that there is a connection. There are kind of in vitro studies that have been done looking at lung tissue exposed to cannabis smoke, and shows that there is mutations that do occur. The epidemiological studies are not clear because we don't have a large number of individuals who have only consumed frequent cannabis without consuming tobacco. So it's very hard to say. So that was a bit controversial. We knew this was going to be a bit controversial to begin with, but then the Canadian press interviewed myself and Tim Stockwell over this, and then cited this and made it an error and wrote 8,851 deaths due to cannabis, and so that's higher than opioids even. Anyway, the cannabis activists just lost their shit. It was a public relations nightmare. Like we were taught, like we wrote, like we tweeted, we just explained our methodology, but because 8,000, like that's a lot. So I don't know, it's the lessons learned. Get your numbers right in the paper, but it wasn't our fault. Like, so anyway, it caused us, we were expecting to get more blowback from the alcohol industry, and all the alcohol industry did was really release a statement just saying this is all bunk, and we're not really looking at all the positive things that have happened in the last little while. But it was really, in a way, the cannabis activists that ended up jumping on us a little bit more, whereas I was expecting this is kind of a good news story for cannabis in a way, like, you know, especially when you look at the crime stats, which I'll show you in a couple of seconds. So anyway, so alcohol costs the most. We already talked about that. One of the things coming out of the attributable fractions calculations with the offender data I was talking about, and this was surprising to me, but not necessarily surprising to some alcohol researchers, is we found that 20% of all violent crimes would not have occurred had the perpetrator not been under the influence of or seeking alcohol. 20%. The industry didn't really like that either. But that to me was kind of like, it's 1 in 5, you know. So how have they changed over time? So alcohol costs have been increasing in Canada. So one of the messages that we were coming out with here was that one of the key messages that we did when we did a lot of media is the media were very interested in this. Anything with dollars on it, they just tend to kind of, that's an outcome indicator that people can relate to. So we get a lot of media uptake on this. One of the key messages was just really like, you know, at least in Canada, for a long time, we've done a pretty reasonable job in our public health outreach with regards to tobacco. I don't think as well as Australia. I've seen some of the packaging and the costs of cigarettes here, so I mean, it's pretty, you're ahead of us there. But we've done a reasonable job. I mean, it's not cool to smoke anymore, really, you know. But at the same time, when we've been doing that, we haven't really done the same kind of public health outreach when it comes to alcohol. And you know, the prices have been generally kind of decreasing in Canada. Availability is greater. You know, like I think availability is greater in Australia generally here, but in Canada, alcohol was only available through government authorized shops for a very long time, and now that's changing in a number of different provinces. They're being available in corner stores and other kinds. So availability is greater and the costs are decreasing, and we know that that's linked to consumption. We just know like that there's just that's a kind of a truism. So you know we haven't done the same kind of work in moving in the alcohol field, and so we see kind of like the difference. And these numbers are, so these are per capita numbers, so they're controlled for population increase, and they're also all adjusted for inflation too. So these are real increases in costs. The other thing is, so then we have the opioids here, and I'll spend the kind of the I'll talk a little bit about cannabis and the criminal justice costs, and then I'll just get really drilled down into the opioids and talk a little bit more closely about that. Cannabis costs increase the most, but they're still even like 1/4 of the cost per person costs us as alcohol. So this is what I was talking about before. So when we look at the costs of the criminal justice costs associated with substances, we break it down into a couple of different categories. So we have impaired driving costs, then we have the drug-defined costs. So these are trafficking, prohibition, or manufacturing of drugs, right? So these are violations of, in Canada, it's the Controlled Drugs and Substances Act. So then we have violent crime and other crime, and these come from the attributable fraction estimates that I told you about using our offender sample. Well, if you look at 3 different drugs, take for example, so look at alcohol. We have 34% of the cost of the criminal justice costs associated with alcohol are for court costs, policing, and incarceration costs associated with impaired driving. 27% are associated with violent crime, and then 39% are other crime. Obviously, there's no drug-defined crimes because alcohol is legal. Cocaine, kind of an interesting one. We have 11% drug-defined, 19% violent crime, and 70% other crime. We found there were really high attributable fractions for other crime and violent crime associated with cocaine use. And then we go up and we look at cannabis, and we have 60% of them are drug-defined. So 60% of the criminal justice costs associated with cannabis is due to the fact that it's illegal. It's possession, manufacturing, and trafficking. So anyway, so this kind of does, you know, this has been used in some follow-up papers and discussions of what are the potential. So right now, there's been a lot of work kind of projecting, like, what do we expect the revenue to be from cannabis when it's legalized? What do we expect the reduction in costs associated with cannabis? Now, it would be false to think that this 60% of would just suddenly we would just get it, right? Because we're still going to have to, probably our impaired driving costs are going to go up because we're going to need to put in place more strict efforts to reduce the number of people who are driving impaired. We're also going to have to regulate, so that the market will need to be regulated, and one of the things that will happen is there will be greater police involvement in stamping out or tamping out those who are selling and manufacturing cannabis outside the legal market. So those aren't going to disappear, but there will be a significant cost savings from our criminal justice system upon legalization of cannabis. There's no doubt about that. What exactly it will be, we're not exactly sure. So then the opioids. So then I'll use this last slide to kind of go into just kind of the story of the opioid crisis in Canada. So in 2014, opioids contributed $3.5 billion, or 9% of all costs. And this was a bit surprising to people in Canada because really all they were hearing about on the news was opioids and fentanyl. And so it's still important. There's, and the reason it's still important is because 52% of the costs were due to lost productivity, and the majority of that was due to premature death. Not only the majority of that due to premature death, but people dying young. And so therefore they had a lot of productive years of life left. And so therefore the cost, so a huge portion of that has been, those early deaths contribute the majority of the costs associated with opioids. We also expect, since 2014, our costs to increase quite significantly, and this is because this is modeled data that we got from the VitalStats database. So these numbers here are modeled. So not only the 100% attributable conditions, but also all the partially attributable conditions, right? So infectious disease, transmission, those kinds of things. So we have here, 2014, our number was about 2,396. The Public Health Agency of Canada, who collects data on opioid deaths, released some figures for 2016, and this is not modeled data, and so we know that in 2016 it increased to 2,816, and then even more recently, in 2017 there was 3,987 deaths attributable to opioids in Canada. So the costs are going, the harms are increasing significantly, and we will see the costs just mirror those. So maybe I'll just jump ahead here then. So our death rate in Canada, I tried doing it. I just did a quick examination here. So we have so we were at a death rate in 2017 about 9.8 per 100,000 population, and in Australia, you would probably correct me if this data is correct or not correct. I got it from the Australian Bureau of Statistics for 2016. It looks like it's less than 5 per 100,000 population, or about 7.5 for all drugs. In the United States, it's more than 13. In the United Kingdom, we were at about 2.1. So Canada's kind of at the leading edge here. Now, this only includes heroin and morphine because that's all they tracked. So why did we get there? This graph kind of shows quite clearly that between the years 2000 and 2010, we saw a massive increase in the prescribing and dispensation of OxyContin in Canada. In about 2013, our organization pulled together a whole group of group of stakeholders from across the country, and really talked about, like, what are we going to do to respond to this prescription drug crisis. So we released this report called First to No Harm, Responding to Canada's Prescription Drug Crisis. Following that, there were a great number of interventions. There were prescription monitoring programs were put into place. There were greater attention of law enforcement to the diversion of prescription opioids. We had greater physician education about the abuse potential or the dependence potential of prescription opioids. But in retrospect, what we really did was we decreased the availability of diverted opioid pharmaceuticals available in the illicit market. And we ended up dealing with some unintended consequences of this because we didn't really address the demand. We just decreased the supply. And then so what did we see? What we saw is fentanyl. Now, fentanyl, you may be aware, like some people have, so there are cases of individuals using the patch form of fentanyl. So this would be like, we hear reports from police of people going going into like old age homes and dumpsters and finding the fentanyl patches, cooking them up and injecting them. But what we were seeing really was really reports from our law enforcement colleagues that there were powdered fentanyl around. So why was there powdered fentanyl? I'm just going to jump ahead here. The reason we started seeing powdered fentanyl was because the market for illicit opioids was largely among those who were seeking OxyContin tablets, but at the same time that there was there was a decrease in, or a greater attention to OxyContin being diverted, Purdue Pharma also took OxyContin off the market and replaced it with an abuse deterrent formulation called OxyNeo. Almost exactly the same time, we started seeing counterfeit oxycodone tablets containing fentanyl. And I know many of you work with or know about people who use opioids. And if you suddenly have a supply of an opioid and you don't know what's in it and you don't know how much is in it, it's impossible for them to do so in a safe fashion. And we just saw overdose rates just go through the roof. And so we released, another project that I wanted to tell you about was this group called the Canadian Community Epidemiology Network on Drug Use. This is really like a knowledge mobilization network that includes people working in a lot of treatment and harm reduction programs from across Canada. These are them here. And through this, we kind of share information on new drugs and new drug use related trends. So when we first started seeing this, we issued an alert on increasing availability of counterfeit oxycodone tablets containing fentanyl. Now at the time, this was back in 2013, we didn't have the kind of I always talk about, like if you think about an early warning system is like a smoke detector, right? A smoke detector to function effectively to save your family from getting harmed in a fire, it needs to detect the smoke, it needs to ring loud enough that everybody can hear it, and you have to have an action plan to respond to that. Well, we rang the bell, not many people heard it, and there was no action plan to respond to it. So things kind of kept moving on, and by mid-2015 or so, we released another bulletin looking at deaths involving fentanyl in Canada. And this was the first time that anybody had gone out to the coroner's offices and actually kind of pulled together data on opioid-related deaths in Canada. We didn't have national numbers. We have national numbers now. The Public Health Agency has stepped in after the health minister indicated this was required, that we really need to know how many people are dying of opioid overdoses, but we didn't know this before. Following this, we released another bulletin, which was a useful knowledge mobilization strategy, I think, where we just simply did an environmental scan looking at what provinces and what municipalities had take-home naloxone programs in Canada. And this was a really interesting project because we started off and it was mainly, our partners were really just interested in knowing who was doing what so they could contact people to share information. But really, it was through this that we kind of, me and a few of our partners talked about how, we called it the quantum mechanics of research. By measuring this, we changed it. So by the time this bulletin came out, it was kind of useless, but everybody had thought, oh, well, what are we doing? Oh, we should do something. We're going to appear in this scan. And so then they got things together and they put something together, and then they got to take home naloxone program. They said, wait, we haven't gotten you your data yet. And then people kind of pulled together. And so it was really, it wasn't intended to be a naming and shaming thing. It was really intended to just be a sharing of information, but it ended up being a very effective way of just kind of just highlighting where there were gaps in the responses to opioids. Some other alerts that we put out in bulletins through the network include the novel synthetic opioids and counterfeit pharmaceuticals and other street drugs, calling 911 in drug poisoning situations. So I know that my time's probably almost over here, but one of the things that I might suggest, because I was chatting with Debbie and some other people today, this is moving on, like this is maybe something that you might want to think about. These novel synthetic opioids, it all depends on your heroin supply, right? But at a certain point, and what kind of heroin you have. But at least in Canada, fentanyl and other kind of synthetic opioids, like these are mainly kind of failed pharmaceutical products that are available kind of online. It's really kind of like, in Canada, the opioid crisis and the emergence of novel psychoactive substances kind of came together at a really unfortunate peak together. And so what was happening is people were ordering a lot of these kind of pharmaceuticals that weren't controlled in Canada, and were mixing them into the powders and pills that were then being sold in the streets. And so we still have, fentanyl's kind of become a mainstay now, and people are actually, they know they're taking fentanyl now. They don't know how much is in it, but they're able to do so slightly more more safely. But one of the things that does happen is occasionally something else will come into the illicit drug supply. So we have seen carfentanil. I don't know if you've heard of carfentanil, but carfentanil is it's a large mammal tranquilizer that's used to kind of immobilize like rhinoceroses and things like that. And really, so the challenge with this is, so the media always jumps on the potency of it, but I always push back to media and partners and say, the challenge with these drugs is not necessarily the potency. The challenge is that as these opioids become more potent, it becomes increasingly difficult for those in the clandestine labs to manufacture products that don't have hotspots in them. So if you pull in a very, very, very potent product and you mix it with a whole bunch of talcum powder or a whole bunch of other powders, it's very easy to get a hotspot. And you make a quantity of this powder or you press it into pills. It's not done as much in Canada now. All of that newly manufactured product is going to be sold, right? So you have a Russian roulette game going on. There will be, if you could take that powder before it's sold on the illicit market and find out how many packets contain lethal doses, that's how many overdoses you're likely to have. So we tell people, in a lot of the messaging that we have, don't use alone, use slowly. Well, we work with our partners who tell people that. But, all of these kinds of, a lot of really harm reduction messaging. And the other thing that it's meant is that some of these overdoses, because they contain so much of these very potent substances, is they will require multiple doses of naloxone. So somebody will have an overdose. They'll be treated with naloxone. They'll be fine for a little while. Well, not really fine. They go, as you know, they go into kind of withdrawal initially. But then the overdose returns. And so if you don't have a second dose of naloxone, sometimes the person can die from a second overdose that comes on after the naloxone is worn off. So it creates a lot of complications. And I think probably my time is up, yes? 2 minutes? Supervised consumption sites, one of the things, so there's been a big, so we, over the last little while, there's been a big move towards more supervised consumption sites in Canada. Right now, we have more than 30 sites in operation now. There used to be just one, Vancouver, which you probably know of. It was, they withstood a lot of court challenges. There was a lot of controversy surrounding it. Now these supervised consumption sites are kind of, are really kind of most places. In terms of treatment availability, we don't have good treatment data in Canada. One of the reasons I haven't talked to you a lot about our treatment is we just don't have good treatment data. We don't know, we don't really have a good sense of whether or not everybody who is interested in treatment can access treatment. We suspect probably not, but we don't really know. We were saying Brian Rush has been here speaking to you. He's really good. He could really speak to this kind of gap. So we just don't really know. So that's kind of, I guess, about it for me. Thank you.